All right. Yeah. All right. So before we get started, I would just like to acknowledge the traditional custodians of the land and show respects to elders past, present, and emerging, and acknowledge and respect their continuing culture and contribution to the life of the regions on which we stand, which I imagine is across Australia. So awesome. I'm currently on Darug land. A little bit about me, well, obviously my name's Jane Palmer. I've been a private midwife for over 26 years now. I'm also a childbirth educator and a lactation consultant, and I've been in business for over 33 years. I started off as a childbirth educator before I was a midwife. Look, I'm really, really passionate about private midwifery practice and have been supporting midwives entering private practice for the last 15 years. I've seen so much change over my career, and I can't wait to share my knowledge and experience with you, and I'm looking forward to hearing from you as well, as best as we can. Now, I look forward to the opportunity to help you start or build your private midwifery practice. Actually, I just might put the chat up just so I can see it in case you guys, whoops, daisy, put that over there. All right, excellent. All right, because there are so many of us, we can't really do an intro, or we take the entire hour, but it would be great if you are able to, maybe in the chat, just say who you are and where you're from. That'd be awesome. All right, so while you do that, I'll just go through what I've got planned for today. All righty, so first of all, I thought we'd just do a Q&A, and I've got sent up Mentimeter. I don't know how that's going to go. I haven't done that before, but let's see if it works. If it doesn't, we'll just move on. I'm looking at, obviously, antenatal items, the birth attendance, postnatal items, telehealth, and the safety net. So I'll go through all the changes that I've seen, and I keep on, the more I research, the more I found. It's quite extraordinary, and it's really easy to see why midwives can get quite confused about what MBS items we can use and in what situations. Great, thanks guys for introducing yourselves. Awesome. Private midwifery practice has seen a significant growth in recent years, and I'd say that is, getting more exponential. I hear more and more private practices being set up, and there's a noticeable increase in the number of women choosing to access private midwifery care as our services increase, and obviously it's because women want more personalised birthing experience. However, the exact growth, I couldn't find exact statistics when I was researching this, but anyway, it does appear to be growing. And Medicare has made private midwifery care more affordable for women. So, all right, so here I'm just going to escape out of this. Come on, computer. All right, now I'd like you to go to Menti. So just go to menti.com using your phone. I hope that this will work. If not, I'll soon find out. And when you log in there, just use the item code that's up on the screen. Can everybody see the item code there? Hopefully. Ah, cool. I'll just wait a few minutes for this. I was just interested to find out how you guys feel about working with the Medicare item codes. So. Awesome. So far, no one feels they've got this. after preparing for this, I don't think I've got it either just yet. I need to do more research, but awesome. Okay. So what I thought is, in Menti, if you could put in any questions you had about private midwifery and Medicare. So that way, at least I know I'm meeting what questions you guys have before I run through my PowerPoint that I put together. Okay. Okay, so not sure what I don't know as I explore the possibility of private practice. Well, hopefully if I go through all the item codes, and I think the number one message about this is what I discovered putting this presentation together is some of the descriptions have changed, and I wasn't even aware that they had. So it's always great to go back to what Medicare have online, and yeah, take it from there. So hopefully I can help you through this presentation. All right, I might just end Menti, and then I can see people are putting questions into the chat. So that might be a great way for us to go through there. So Ruth has said she's confused about 82103. And oh yeah, do you have to have admitting rights? Yeah, I've got, it doesn't specifically say this, but looking at Medicare rules, hopefully I can answer that, Tracy. So all right, what I might do is I will, yep, go back here. All right. So what, when I started, I thought I'd just quickly put all the Medicare item codes in a table. You can see that we've gone from a few Medicare item codes to lots of Medicare item codes, and they've all got obviously requirements for us to be able to use those when either bulk billing, if that's what you choose, or help in giving women, you know, ability to rebate from any care that we've had. So I'll just have a quick look. Okay, so do I need to provide a number to claim Medicare? Yeah, Roxy, most definitely. So to claim Medicare items, you have to be an endorsed midwife. And then once you've got your endorsement, you can then send off the application to Medicare. I know some people had, I saw a little bit on chats that people had done that without being endorsed, but you absolutely can't do that. Medicare will chase them. I think they've filled that. Pardon me, that filled that little gap in their services. So yeah, so to become endorsed, it's a little bit outside of this presentation, but to become endorsed, what you need to do is you need to have 5,000 clinical hours. Yes, you need to do the prescriber course. And then, yeah, if you go to the NMBA website, they've got all the details of what you need to become endorsed. So once you've fulfilled all the criteria, you just submit the application to AHPRA and take it from there. All right. So this is the summary of the antenatal, I'm just going to move you guys, you're in my way, antenatal visit item codes. So some of the changes. All right, so of pretty much like when I had a look, sorry, I've got a little notes here for Jane. When I had a look at our antenatal item codes, you can see I put it in a table as I find that easier to understand each of the item codes as a basic. So 82100 is the initial antenatal item code. This visit must last at least 60 minutes. The scheduled fee has gone up for this one, which is awesome. It is now $84.70, so that's the scheduled fee. But mostly women will get an 85% rebate from Medicare, which means that you can only do this one as not as an inpatient. You have to be in the community. And there is a safety net cap on that, which I'll explain in a little bit. So there's some details. So when I look at the item details on Medicare, you've got to basically be take a detailed patient history, perform a comprehensive examination, perform a risk assessment, and based on the risk assessment, you may need to arrange referrals or transfer of a patient's of a woman's care. You request pathology and any diagnostic imaging as necessary. You can only claim this item once per pregnancy. All right. So that's pretty straightforward, but I'm really, because the rebate's gone from, I think it was about $51, and it's now $72, which makes it a lot better rebate. A, if you bulk billing, or B, for the woman, she'll get a lot more money back in the long run with all these new changes. The new item, which is 82102, which is called a long antenatal, and the previous long antenatal's been renamed, but I'll get to that in a minute. This one must last at least 90 minutes, and you can see the scheduled fee there, and you've got a 85% rebate and a 75% rebate. So for those of you who don't know, 85% rebate is when a woman is not admitted in a hospital, so you're seeing her in the community somewhere, or the 75% rebate from Medicare is if she is admitted as a private patient. Any of these item codes to claim when they're admitted in hospital, you must be involved in the care and they must be a private patient. I didn't find an exact definition before this presentation. It's a bit of a shame, but that is, yeah, so they've got to be private. You can't use this one if women are admitted as a public patient. So I hope that makes sense. All right, now, whoops, daisy. The one the questions was about was 82103. Now, when I looked at this one, where have I got my notes? There they are. There wasn't a lot of information on Medicare, which I was very surprised. All the new item codes only have very brief descriptions, which makes it a bit more tricky. But this is a complex antenatal professional attendance by a participating midwife leading to a hospital admission, and it must last at least 3 hours. Now, when I put the summary together on Instagram, I said they had to be seen 3 times during their pregnancy. That was an error. You are able to use this item code a maximum of 3 services per pregnancy. So you can use this item 3 times. There didn't seem to be any pre-criteria or anything, or nothing mentioned. And you can't use this item where it relates to intrapartum at all. So if the woman's in labour, so it must be an antenatal one. So she must be admitted, and the woman, or if you're bulk billing, will only be a 75% rebate of the Medicare scheduled fee. Does that make sense? So okay, so sorry, I'm going to go back. So Lily says, what does a scheduled fee mean? So Medicare set a scheduled fee. That it's just an amount they put out there, and it's kind of like a suggested fee, but obviously it's quite low for potentially what we need to, per item. So it's just their set fee. So when we bulk bill, or when a woman gets a claim for a particular item code, typically they'll get 85% rebate if they're in the community, or a 75% rebate if they're in hospital. If they've exceeded the safety net, which I'm going to go on to in a minute, that the Medicare will cover 100% of the gap up to the scheduled fee. So I'll explain that in a minute. Okay, so yeah, so someone says, when we bulk bill appointments on HPOS, do we put the 85% rebate as the benefit assigned? Typically you do. So you would put, I just used HPOS for the first time. I actually used best practice software, but it was didn't have the new item code. So I played around with it this week. And yeah, you had to put in the 85% if you're in the community, and that come back. Obviously, if you're inpatient, you're billing, you put the 75% rebate. All right. Sorry, I'm just going back on the questions. I've done that one. Yeah, no, so I'm up to date. Awesome. All right. Yeah, so that's pretty much all about the 82103 that I could find. If anybody has anything else, please put it in the chat. That'd be great. Awesome. So the short antenatal, whoops, today's I keep moving it and I shouldn't. A short antenatal visit, the actual description of this has changed slightly. It is now a minimum of 10 minutes. So they actually had up to, I think previously it was up to 20 minutes, but now there's a requirement that we must see the woman for at least 10 minutes. Sonia said, does that mean 82103 can only be claimed if you have visiting access? Sonia, as far as I can read, if she's a private patient and you're providing the service, you can claim it, but I'm not 100% sure on that one. So I don't know if anybody else has interpreted it any differently, but she must be a private patient. You must be caring. So in reality, I suppose, yes, it'd be ideal if you have visiting access. But it depends if some of that, yeah, I don't know. Can anybody else answer that question for Sonia? All right. Sorry, I was just talking about the short. So essentially short antenatal hasn't changed, and the amount of money rebated for that, that one hasn't changed either. All right. So the next one is our 82110. That has had a name change. It's gone from being the long antenatal to the routine antenatal visit. The timing and the details around it doesn't seem to have changed, but one big change, it has gone from being $51.75 it is, I think, to $72. Yeah. Tracy, I'm going to say, so Tracy says if you see the woman for 3 hours and then hand her over to the hospital staff, does that satisfy 82103? From what I can read, Tracy, yes, it does appear to. So, yeah, I'm going to say yes, but that's my interpretation of it. Awesome. And the maternity care plan, which I don't think that's changed too much. I mean, it's got quite a lot of criteria that we must include in it. But so obviously it has to be a 90-minute appointment and assessment and preparation of maternity care plan, who's a woman whose pregnancy's exceeded 28 weeks, and you had to have seen them in the 2 last antenatal appointments in the preceding 6 months. Now, this is a bit of a tricky one. I don't know if others have had trouble, but I've been seeing women in my clinic with this, and GPs are claiming it even though they're not doing maternity care, which I think is quite crook. I've actually submitted complaints every time it's happened, particularly for women have only seen them once or whatever, but the GPs are doing it. But with this particular item code, yeah, it can't be admitted in hospital. It has to be in the community. You've got to develop a detailed plan. You've got to have any health problems and needs. Detail any medication taken by the woman and any additional medication that may be required. Details of any referrals or requests for pathology services. And obviously the woman's got to agree for you to do the maternity care plan. And the fee doesn't include any amount for the management of labour and birth. And we can only claim once as well. Yeah. Awesome. So any other questions with the antenatal item codes before I move on? Nope. No, they're pretty straightforward except for 82103, I think. And I'm sure we're going to have a lot of discussion on that one as we go forward. All right, now it won't go. Yeah, so Tracy's written, GPs are not obliged to have to meet the criteria for the 2 previous visits. And yeah, and I think that's wrong. And I've actually been thinking, thinking that you know, I was going to approach the college about that myself, because it's so unfair that we have to have two, yet they can just claim it without actually having to do it. So what you've got 82102, the 90-minute, that you can, there's no limit on the new long antenatal appointment. That one you can do as many as long as it's clinically relevant. There's no restriction on how many times we do the new 82102, which was, yeah, the one up to 90 minutes. Awesome. So the labour and birth, I spent ages going through this as well, my goodness. But yeah, I like it, as I said, I like it in a table. So feel free, as I've got this recorded, so you'd be able to look back on it if you like. So I've just put all the item codes and what they relate to. Obviously, the management of labour out of hospital details, that came in a little while ago, and that's awesome. So you can manage a woman outside of the hospital so long as the woman doesn't give birth while you are at home. Otherwise, you cannot claim this. And then it says the attendance, the requirements just say the attendance is by a participating midwife who provided antenatal care or is a member of a practice that provided antenatal care, and the total attendance time is documented in the woman's notes. And it's only claimable once per pregnancy, but it doesn't appear to have any other criteria on it. So, which is so awesome. So it doesn't look like you need to have visiting rights or, you know, access agreement for this one to be claimed. Okay, so Marianne's just said, do we require a written referral for an antenatal antenatal woman? No, we don't need referrals at all anymore. So thank goodness the collaborative agreements are now gone. So women can self-refer. Okay. So Rachel's got, but it's not for a planned home birth. Yes, that's correct, Rachel. So the 82116 is not for a planned home birth, because it does say if the woman gives birth outside of the hospital, you cannot claim this item. So yeah, awesome. So the next one, obviously you do have to have a visiting agreement at the hospital to claim the next ones. Okay. Sorry, just keep up with the questions. 82116 needs insurance for labour. Yes, I'm going to say yes, because if you are caring for somebody during labour, you'd have to have insurance during labour. I've had this conversation with MIGA before. Also, if you only do home birth and don't have visiting access, that they obviously say you have to have insurance, the intrapartum insurance. So I've seen a bit of debate online. That's what they've told me. I haven't seen it in writing, but that's what they said. When Medicare stipulates things we need to do in the appointment to meet the criteria, is this just in our regular notes? Yes. So you've got to just make sure you've got really good documentation in case Medicare audit. I have been audited by Medicare myself, and yeah, they ask for tons. You've got to prove everything. You don't need to submit the documentation to Medicare. They will ask for it if they audit you. Yeah. Oh yeah, Rachel's just said that. Sorry, Rachel, didn't see your message there. Awesome. So we were up to 82118. So that's just management of labour by the first midwife that's caring for the woman. And that is if she's only there up to 6 hours, and obviously the scheduled fees there. Sorry, I'll just go to the rebate. Obviously the first one, 82116, is 85% because she's not admitted to a hospital, but with all the other items, it's only 75% rebate because she is now admitted in the hospital. And yeah, so you can see this, the scheduled fees of each of these and the 75% there. So 82110 is for the first midwife up to 6 hours. 82120 is if the first midwife is there between 6 and 12 hours. Then obviously then a handover to a midwife in the same practice. And then, so that's the second midwife. Okay, sorry, I'm just reading to Neil's message. So the 82216, you can claim this if you're only caring for them at home and then they go into the hospital by themselves, as you don't have to have visiting rights. Well, you'd have to take them in and hand over, but it doesn't actually say that in the description. but good clinical care would say that you would hand over if they were going in as a public patient. Yeah. Please, anybody disagrees with what I say, please put it in the chat. Awesome. Sorry, I'll go back to the items, the labour items. Okay, so we've got the first midwife. So the second midwife hands over. The first midwife hands over to the second midwife, who also has to have visiting access, and she can either claim an 82123 if she's only there up to 6 hours, or if she's between 6 and 12, she can claim an 82125. And there is now provision for a third midwife, which is awesome. Obviously the same practice. And I think there had to be 12 hours between the first, so if you only got, obviously if there's only 2 midwives caring, there had to be 12 hours between her leaving and coming back. But the third midwife claimable item is only up to 6 hours. Obviously you just use that one if you were there longer. So cool. And pretty much all the requirements of these are all the same. So pretty much, you know, they have to be, you had to assist or provided the patient's antenatal care and be a member of the practice that's provided the antenatal care. And then, yeah, and so pretty much the criteria is pretty straightforward for these ones. And all of them are pretty much claimable only once. And they do state, as you go through the description, for example, if you try to claim an 82123, you can't claim an 82125. So you either have to claim as a second midwife, you have to choose. As the third midwife, you've only got one option. As the first midwife, you have to choose between the 82116 and the 82118. All right. Excellent. So any further questions or comments at all on the birth Medicare item codes? Okay, so Judy said, so if the first midwife went back a second 12-hour stint after a 12-hour break, she would then claim it twice? No, she would claim, so she would probably claim an 82118 or an 82120. So she'd claim that the first time. When she came back, they'd have to claim an 82127. So she would be potentially become a third midwife. So Holly Jones says she's working on her independently and not part of a practice. What does this mean for second or third midwives? Well, if you read the requirement, Holly, it basically says the attendance by the second, so I'd use a second participating midwife in this case, has to have had assisted or provided the patient's antenatal care, or is a member that provided, or sorry, I missed the important, or is a member of a private practice that provides antenatal care. So it looks like you have to be in the same practice or have, you know, a setup like when I worked with midwives at Sydney Beyond, we all had our individual businesses, but we all worked under an umbrella. So we belong to a practice. So maybe setting up an agreement with other local practitioners. I don't know. That's just a thought, Holly. Awesome. I will move on to postnatal care items. Okay. Yeah, so if the second midwife has met the mum at a previous appointment, they could then claim it. Yes, that would be a yes. That's the way I interpret what Medicare have written. Awesome. So for postnatal Medicare items, obviously, we've got the new 82104, the long postnatal visit, which is amazing because most of my postnatal visits, particularly in the early days, or if there's breastfeeding issues or whatever, last at least 90 minutes long. And so now there's a specific item code we can now use for this, and it's got a really decent rebate. So the scheduled fee is $186.75, and the 85% rebate is $158.75 if you're in the community. If you are providing postnatal care in the hospital, obviously you have to use a 75% rebate for the woman. which is awesome. So, and there's no limit on this one, so you can use it as many times as is clinically relevant. All right, so the short postnatal visit is pretty much the details on that haven't changed. It needs to last at least 60 minutes and be done within 6 weeks after the birth. And also the rebate on this one has gone up. It was 30, I think, so the scheduled fee at the moment is $60.85, and the 85% rebate in the community is $51.75. From memory, it was about $32 or something prior to the changes before the 1st of March. So it's gone up with $20, which is, or approximately $20, which is great. And obviously it's a 75% rebate if it's a quick visit in the hospital. Routine postnatal is obviously, that's had a name change. It's gone from long postnatal to routine. So it's like, so they need to last at least 40 minutes. You can see the scheduled fee, and the rebate is $105.85 now, which again is awesome because it was about $71 off the top of my head prior to the 1st of March. So that's gone up a good $30, which is great for women actually. So they're going to, if you add all this up, they're going to start to get a lot more back. You also notice, sorry, I didn't discuss this, but all the new Medicare item codes don't have a safety net cap. And as I said, I'll explain what that is, which is really surprising. And so, yeah, when I get to talking about the safety net, that might actually get even more money back for women, particularly for those of you who charge a set fee for the labour and birth and then itemise each of the visits after the birth. Awesome. So I'll just go through these and then I'll look at my questions. Okay, so we've got the short, we've got the routine, we've got the 8 to, oh, sorry, I put that one twice. Must have been like that one doubly. And then obviously we've got the final postnatal visit, which is 82140. Now this is a visit that the description of this has changed. It can be done anywhere between 4 weeks following the birth to 8 weeks following the birth. So previously it was done between 6 to 7 weeks. So now they've changed the description to say it's between 4 to 6 weeks. I don't think the rebate's gone up on this one, if those figures are correct. I'll have to check this after the presentation, but it's, I think, yeah, I'm pretty sure that's correct, but I'll go back and have a look. I didn't have time to proofread it. And there's also quite a detailed description of what you've got to do in that final postnatal visit, and it all needs to be documented. So I'll just read what Medicare said. So the final postnatal visit, postnatal professional attendance by a participating midwife on a woman not less than 4 weeks, but not more than 8 weeks after the birth of her baby. This visit must last at least 60 minutes and include all of the following: a comprehensive examination of the woman and her baby to ensure a normal postnatal recovery, a labour and birth debrief, a mental health assessment, and referral of the patient to a primary carer for the ongoing care of the woman and her baby. If the woman chooses not to do a mental health assessment or doesn't want you to do that, a record of patient's decision not to undergo a mental health assessment or accept a referral to a primary carer must be recorded in the woman's notes, and you can only claim this one once a pregnancy. All right, so I'm just going to go back, sorry. Okay, so I've answered the woman's plan. Okay, where am I up to? All right. Okay, so yeah, so Tanya says, can you claim the long postnatal until 8 weeks? No, you can't. You can only claim it up to 6 weeks, as in the description. If you only do postnatals and not antenatal or birth, is that okay? Yeah, Roxanne, yeah, definitely. So there are midwives who choose just to do postnatal care. There are midwives just who choose to do antenatal care, and obviously those that choose to do care across the continuum. Okay, if a woman has transferred to hospital during a planned home birth, I'm assuming you can't claim a postnatal visit as they are an inpatient and it's essentially a social visit. So you need to be the carer providing a postnatal visit. If they're a public patient, no, you definitely can't claim. And I would assume, look, if they're in hospital admitted under an obstetrician, if they're private, well, then they're responsible for their care. So you kind of need a referral back if they're a patient, so a woman admitted. So yeah, that's the way I understand it. Yeah, so Rachel says, I don't understand why we would use an 82140 instead of an 82135 or an 82104. Exactly, Rachel, I agree. I suppose the only time you would anticipate doing that 82140 is if the woman is past 6 weeks. That would potentially be, pardon me, why you would use it. I suppose that's my way of thinking. Yeah, Tracy says, I agree, the last visit is very comprehensive. Absolutely. Yeah, what they require is a lot for the poor rebate compared to our routine postnatal assessments, which we could always do those things. Yeah, no, I totally agree. So if any other, oh, hang on, there's more messages come down. Oops. Do you have a table of the postnatal visits? Also, Rochelle, is that not what's up on the screen? Is that what you mean? And Amanda has said the mental health assessment is another Edinburgh, scale would be it. Okay, so Marianne says, is 82135 only applicable as a home visit? No, if you've got a clinic or are seeing the woman in any sort of private facility, you can use either an 82104, an 82135, an 821. You can use them all pretty much. So Rochelle says, isn't 6 weeks and 6 days for postnatal? No, it says up to 6 weeks. Let me quickly flip back just to make sure I'm not telling you. No, it says within 6 weeks after birth. So that for me is not 6 weeks and 6 days, it's within 6 weeks. So yeah, which is a bit of a shame, but it'd be great if it was 7. What about shared care clients? Can you claim postnatal visits? Yeah, absolutely, you can. So you don't have to have a collaborative agreement anymore. So if women want to see you following the birth, once they're discharged from the hospital, you can see them, even if they're being seen by midwifery at home, because they are no longer, or whatever the hospital service is, because they're no longer admitted as a patient in hospital. What if we claim a postnatal home visit and don't realise it's last? I don't think that matters, as long as the woman is within 6 weeks. There's no requirement that we have to do an 82140. It's certainly not written into the descriptions. Yeah, so just clarify that last point. No, so Helen, 82135 is up to 6 weeks, not up to 8, unfortunately, which I wished it was. Awesome. So how are we going time-wise? No, we're going good. Alrighty. So there's been a lot of, I went on the Endorsed Midwives Facebook group just to see what sort of questions were out there as I was preparing. There was a lot on telehealth. All right. So I thought I'd put a bit up here on telehealth. Okay, sorry, Marianne's just put a postnatal question. If an obstetrician asks for a postnatal visit in hospital for a woman, I would need a written referral. Yes, that's correct. So he needs to refer the woman back to you, and then you can claim postnatal visit if she's still under the obstetrician's care. I don't think it's relevant once she's discharged, but yeah, definitely in hospital you would. All right, so Medicare, basically Medicare telehealth video and phone items obviously came because of COVID pandemic, and now thankfully they are permanent and a great part of our care. And the services may only be provided by telehealth where it's safe and clinically appropriate to do so. They're not for in-hospital. So if women are admitted in a hospital, you can't use them, and you must obtain financial consent from the woman prior to providing the service. Now, that QR code just went to where I started looking at the MBS telehealth items, and it took me off to multiple different websites. So I just thought I'd put that QR code, and that little graph up there is just a summary of the telehealth items that we have. So they're comparing the face-to-face, the telehealth via video and telephone items. They do say in their description, video conference services are the preferred approach for substituting face-to-face consultation. Now, I've had trouble with women, particularly depending on, I've got a lot of non-English speaking women in my area that I provide care for, and some of them struggle with video conferencing, so I end up doing mainly personally telephone consults. Obviously, if it's breastfeeding, video would be awesome. And you don't have to have any specific equipment. They kind of listed things like, you know, Zoom even, or those sorts of things that you can use for video, FaceTime. But you can't count anything on social media, anything sent electronically. It has to be you providing care either by video or on the telephone. Nothing else meets the telehealth requirement. No, Tracy, that's actually not correct. You can claim a Medicare item number, and I'm going to get onto this in a minute. Tracy said, just remember, you can only claim Medicare and item number teleconference if you're seeing the woman face-to-face first. Actually, I'll flip across to the next slide. Let me just, no, I haven't missed anything there. All right, so I'll get to that in a second, Tracy, what Medicare actually said about that. So here, I'm not going to go through them all. They're all pretty straightforward. There has been an increase in the long visits, which is great. The short doesn't look like it has changed much. Now, the description of short video and short, so short video and short telephone, but both antenatal and just for antenatal, has a minimum of 10 minutes. So that's to stop women ringing up and needing a script, or they need something very quick. We can't claim a telehealth item in that case. It must be 10 minutes or more. And you can see all the Medicare scheduled fee and the 85% rebate, because remember, you can't use these for women who are admitted in a hospital. So yeah, so that's kind of the summary of all the items, and you can see like a routine postnatal video now is $105.85, where that was about $71. So, which is awesome. Now just see, I don't think I've got any other notes on this page. Postnatal, yeah, postnatal is 20 minutes, Mari. That's what I got. Now, you might need to double check. I've been working on this in the last week, putting all this together, but it was 20 minutes. It was antenatal that was 10. Anyway, if I'm wrong, I will let people know. I'll send a message. But yeah, from memory, it was 20. Okay, yeah. If telehealth prompts you to do a home visit on the same day, could you claim both? Good question, Yvonne. That's kind of the question, like, can you provide two services? So I did see one question somebody said was, if I did, let's say, a 2.5 hour postnatal visit, could I claim two 82110, sorry, where am I? 82135s, for example, which is the more than 40 minutes. Or you claim the new item code, which I'm not going to go back on the slide, but I think it ended in the 3. You can't, if it's a continuous visit, you can only claim one item code. But if you saw them in the morning, so let's say you did a telehealth at 10 o'clock in the morning, and then that prompted you to, she needed to do a home visit, and you went and visited her at 2 o'clock in the afternoon, yes, you can definitely claim for both, because there's a clinical reason to do it. They're two separate visits. You have to be very specific when you claim for Medicare. Put the time on and say second visit on same day with the second claiming. Sorry, I'm going back. So someone says 82116. So that's going back to the birth. That's Celia. Going back to the birth item codes. yes. Do you think this would apply for a home birth that transfers prior to birth? Yes, definitely, because there's nothing there, because the woman is birthing in hospital. As far as I can see, it's claimed in the community because it's an 85% rebate. So even as a planned home birth, yeah, you could claim that. Anybody, as I said, please disagree with me if you think you're wrong, but that's the way I interpret 82116, which is, you know, care at home prior to birthing in hospital. Yeah, awesome. So I'm just going to go on, so get back to the next question. So this is in relation to where have I lost you? It was, sorry, too many questions coming through. Anyway, where we have to do, here we go. If telehealth, you have to, so with telehealth, there's a perception that we have to see them face to face first, and that actually isn't the case. So this is taken from MIGA's product guide. So what, you know, when we're covered by insurance. So basically they agree to cover you for any telehealth services that are obviously clinically relevant. No cover or claim for expenses if you provide telehealth that's not conducted in accordance with any applicable lawful requirement issued by government. So that's pretty straightforward. Where information relating to telehealth patient is communicated electronically. So that includes email, web chat, social media, message group. As I said, it must be either by telephone or by video conferencing. Except, now hang on, let me read this correctly so it's a bit okay, so midwifery services, except in the following, where midwifery services that are provided during initial consultation by real-time telehealth technology. So you can do the first visit, all right, but you can't have a totally telehealth service as a midwife. You have to have a pre-existing clinical relationship with that woman, or see her, or if you're being given prior access to her medical records by telehealth patients. So it's a bit long-winded, but the way I read that is you can't do, you must follow the law, which is obvious. You must be can't communicate other than via video or telephone. You can provide the initial consultation, but you do need to see her face-to-face at some point, or be given prior access to the medical records of the telehealth patient by another practitioner, practice, or to whom which the telehealth has a previous existing clinical relationship. Yeah, so does that make sense? So yeah, for those of us that want to run just a purely telehealth service, we can't do that, but you certainly can see them for the first time by telehealth, but you will at some point have to see them face to face. Yeah. Any questions regarding that? No. Okay, I will move on. This time's getting along. All right, so the Medicare safety net. Now this gets very confusing, but this is really, it's not in relation to women who are being bulk billed. This is women who are being privately billed. So the safety net is helping people where there's high out-of-pocket costs across all sorts of medical costs. So if you've got someone with IVF, they often will have hit the safety net, so they'll get more rebates than someone who hasn't. There's certain limits on certain out-of-pocket costs, like as you saw on some of our midwifery items, where there was an amount, they would only get that extra bit once they hit the safety net. So the gap expenses and out-of-pocket, so it just depends. So if I'll just go on to the next slide. Annie says, if a GP makes a referral, does that constitute a medical record? No, because we wouldn't have access to her medical record at the GP practice. That's the way I interpret it. Yeah. All right. So this is the safety net thresholds for this year that I quickly looked up. So the original safety net is when you have out-of-pocket costs. So this is the gap between the fee and from the Medicare rebate and the fee. Once you're out of pocket more than $576, either as an individual or a family, you'll get 100% of the scheduled fee for out-of-hospital services. So once you hit that, so you'll hit that first safety net. Now, the extended safety net is for everybody that doesn't have a healthcare concession card or family tax benefit Part A. So as a family or an individual, you have to have this year $2,615.50 out-of-pocket cost before you hit the safety net. And then that means, so from what Medicare rebate to the gap, you get 80% of these out-of-pocket costs, except where there's a cap exists. So, for example, if there's a $20 cap, you'd only get $20, even if the gap was $80. Yeah. Okay. And then the extended safety net, the lower level, is for the concession card holders, etc. So it really comes into account when you do package care and stuff like that, that if you charge a woman a management fee, well, they don't access any of this. But if you charge them individual amounts for each of the services, you know, let's say it's an antenatal visit and you charge them, I don't know, randomly $180 for an antenatal visit, and the rebate was, I forget now, I have to shut that window down, I think it was $72. So the gap between 72 and 180, they would get a portion of that back, depending if there was a cap or not. So yeah, if you've got any questions on the safety net, but it does make for more rebate for the women and make midwifery care more affordable. Now, I know all this is confusing. Oops, doesn't want to go forward. But, oops. So primary healthcare networks are set up across Australia, and they are designed, essentially they're put together for GPs, but they're essentially there for anybody who uses Medicare services. So if you have any issues with Medicare or anything relating to being in private practice, the primary healthcare networks are supposed to help you. They get a bit confused about private midwifery, depends on the area, but yeah, they are another resource that you've got. Obviously, you can always contact Medicare if you've got any questions about Medicare item codes, but my experience is you get different answers every time you ring Medicare, but that's just me. All right, now I just threw this in. This is just a screenshot of a spreadsheet I have. So when I no longer attend births, I stopped attending births a few years ago, but when I did attend births, so let's say I charged the woman's fee for her episode of care was, in this case, $6,195. I would put the number of antenatal visits she had in like each of the different item codes in the spreadsheet and then work it out. So that I work out how much can add up to the fee. So I just have a workable spreadsheet like that. So obviously I haven't added in the new Medicare item codes, but yeah, this just helps me invoice the women. This helped me invoice the women once the care was finished, so that they can claim the rebate back for Medicare. It was just an idea I had, and I just thought I'd share that with you. All righty. Excellent. So is there any other questions on the Medicare item codes at all, or any comments? Feel free to use your microphone if you want, because yeah. Roxanne says, is there any Medicare item codes for childbirth classes? That's a no, Roxanne. Sorry. I wish there was. Yeah, have health fun. Yeah. Yeah. Oh, no, that's my pleasure, Rochelle. So, look, I am, as you all probably know, I'm running a private, we've just renamed it, by the way, building a private midwifery practice. It was formerly known as your private midwifery practice, getting it right. And that's starting on the 18th of March. So it's run over 3 weeks for 2 hours, which covers lots and lots of things in detail for private practice. So I'd love for you to join if you're interested in finding out more. If you want to get the 20% off, you use this coupon code, and that will get you the discount for the next 24 hours. So yeah, really encourage you to come along, and also check out Birth International's website. Yeah, we've got so many new products and stuff for midwives and childbirth educators coming across. All right, Helen has said, am I right in thinking that you can't bulk bill women ourselves and then charge a fee? Yes, that's correct, Helen. You can either charge a management fee for the whole pregnancy, or you charge the set fee and then claim it back from Medicare. Yeah, awesome. Yeah. Oh, thanks, Marianne. That's great. yeah, it was a good exercise for me to do, to go through, because obviously running the private practice workshop, I need to be up on all the new changes. So that's why I thought I'd put this together and get everybody together sharing and whatnot. So yeah.
So, Jane, it's
Yeah.
Tracy from Broome, just asking a question, because there's a lot of, just trying to get your head around private practice and charging and
Yes.
what to do.
Mhm.
I'm just wanting to ask, if you charge an admin fee at the beginning of the pregnancy, are you then able to bulk bill the woman consequently for each appointment after that?
Yeah, definitely. You can.
Okay.
And
Okay.
a lot of practices do that.
Yeah.
You know, I know of a practice that I used to only bulk bill and found women just didn't value the appointment. But once they put a small management fee, the women then started to turn up to their appointments.
Yeah.
So yeah.
Okay. Yeah.
Awesome.
So it's just trying to, so thank you. No, it's been really informative. I think there's a lot of stuff here that I need to have a look at.
Yeah, and even me, after I found another page like half an hour before this webinar, going, there's even more information that I just found. And it's not easy, and it's really tricky for us to put all this information together. So yeah.
Yeah, I think I'm probably going to be looking, once I get a little bit more into, I think I'm probably even going to have to engage the services of a VA, because you just need to be able to do your practice, and then so, but no, thank you, I really appreciate it.
No, yeah. Helen's just got a quick question. Approximately what might a management fee be? That's very much up to yourself. The practice I was talking about just does antenatal and postnatal care, and I think theirs was about $180 or something. But obviously, if you're doing continuity, you would probably make that a lot more. But just remember that woman doesn't benefit from the management fee. That's just my way of thinking. So that's why I like to bill individually, so they get more money back in the long run. So, but yeah, all good. So anyway, so obviously join me at the private practice if you like, and check out Birth International. And there's my email if you want to flick me an email. And please follow our Instagram page. Oh, sorry, Roxanne, one last question. With telehealth, if someone calls you and it's their first meeting, you can ask for their and call and make a claim through Medicare and get paid for the call. Yeah, as long as it meets all the criteria and you're doing a detailed clinical assessment over the phone, you can claim for the first, but you've got to see them at least, like with a GP, you've got to at least see them once. So our requirements are no different to a GP. Awesome. Well, I might leave it there, guys, and thank you very much. And I will make this available on YouTube, on Birth International's YouTube channel, once I work out how to do that. All good. No worries. So thank you, guys. And we'll see you, hopefully soon.